This gentleman presented with right-sided facial swelling and pain. So you can see there's already some swelling, some edema, fat stranding on the right side of the face. And now I'm scrolling down, I'm at the level of the sinuses here, and you can see an air fluid level in the right maxillary sinus, and probably some bubbles. See that? So when you see air fluid levels, especially with a bubbly, frothy appearance, you want to think about acute bacterial sinusitis. When you just see mucosal thickening, it's non-specific. It can be viral, it can be chronic, it can be allergic sinusitis, but it's not acute bacterial sinusitis. So we think there's at least acute bacterial sinusitis going on in this patient. So I'll keep scrolling down. I don't think that fully explains the swelling outside of the sinus though. So at this level you can see there's abnormal soft tissue density here in the nasolabial fold and just anterior to the maxilla, and there's some stranding within the subcutaneous fat of the cheek as well. And some of the swelling extends down to the tissues over the mandible, but it doesn't seem to be the epicenter of the swelling. So I want to figure out what's going on right here. So I'm going to look at the teeth and switch to bone windows. Let's see if we can figure out what's going on. Let me window it a little bit more so you can see all three tissues of the teeth. Okay. So take a look at this tooth, the right maxillary first premolar. There's decay involving the distal aspect of the tooth. There's demineralization of the enamel, and then there's demineralization of the dentin. And this is a very typical pattern for decay. Because of the way enamel is structured and dentin is structured, the demineralization in the enamel is just a very small, thin layer, and then it fans out into the dentin. And then you can follow the decay and the demineralization. When you get to the pulp, you can't see the decay because the pulp is already radiolucent. But you know the pulp is involved because when you go all the way to the apex of the root, there's, let's see if I can brighten this up. There's a periapical radiolucency. So we know the decay went from the crown through the pulp of the root and out to the periapical tissues. Something that's really important to note is this cortical dehiscence here. Right there. Always look for this. This is why there's soft tissue swelling around the maxilla. If you have a periapical radiolucency, even if it's an abscess, if there's no cortical dehiscence, you don't get the extraoral facial swelling. And this does appear to be right in the epicenter. Let me switch back to soft tissue windows of all that swelling. It's an important finding, that cortical dehiscence, because many times there's radiolucencies of many, many teeth. And you want to be able to tell the doctor or the surgeon or the dentist, of course they'll do their own exam, but you want to be able to tell them which tooth is causing the extraoral swelling. And in this case, I think we can fairly confidently say it's this one, that one. But obviously there's radiolucencies, there's just decay elsewhere. So that's a little helpful tip, is looking for the cortical dehiscence. Okay, the next thing I want to show you, let's go to the coronal plane. Okay, here's that same tooth, that right maxillary first premolar with the thinning and cortical dehiscence on the, it's called the labial or buccal side. And then you have the soft tissue swelling, which you can better see on those windows. Okay, now let's go posteriorly. So let's look at these roots. So these little root tips here, they're decayed. there's periapical radiolucencies, but these are draining into the oral cavity. There's no cortical dehiscence here. These wouldn't be causing extraoral facial swelling. These may be abscesses, it may be a lot of decay, but this is not causing the extraoral facial swelling. So what about this tooth? You've got little periapical radiolucencies around the root. Let me window this, let me blow it up as well. There's also the suggestion of cortical dehiscence at the floor of the sinus. So that's pretty important, because I told you the infection, the inflammation goes where the cortical dehiscence goes. So what is this suggesting? Maybe this maxillary bacterial sinusitis is from the tooth infection. That's not a slam dunk case. I wouldn't say for sure that this is what's called odontogenic sinusitis, but I certainly would suggest the possibility of it. And it's important to mention because the treatment is different. Generic run-of-the-mill sinusitis gets antibiotics, but odontogenic sinusitis, you need an extraction or a root canal. You need to treat the tooth, because if you give the patient antibiotics, they'll maybe feel better for a day, a couple days, but it's going to come right back because you haven't removed the source of the infection. I'll tell you that I really do think this is odontogenic sinusitis in this case, and here is why. The maxillary sinus, the ostium is patent, the infundibulum is patent, the meatus is patent. There's really no reason for the sinus to be obstructed or have sinus disease. So I would strongly suggest odontogenic sinusitis in this case. So this is a case of decay involving the right maxillary first premolar with a cortical dehiscence and extraoral facial cellulitis. And there is also decay involving, this is the right maxillary second molar, with possible dehiscence of the floor of the sinus and a finding suspicious for odontogenic sinusitis with air fluid levels in the maxillary sinus. So the teaching point is look for the cortical dehiscence. It'll help tell you what tooth is causing the problem, and it may suggest an alternative cause of sinusitis.